Charles Weaver. I am the founder and publisher of the RA Connection. I want to thank you for joining us today for a web chat with Lynn Schaefer-Alphonse on how to track your rheumatoid arthritis. Lynn Schaefer-Alphonse is a nurse practitioner who joined her team of colleagues at Seattle Rheumatology Associates 8 years ago. In this private practice, she manages patients with a variety of rheumatologic conditions and is a sub-investigator for numerous clinical trials. I will now turn the presentation over to Lynn.
Hello, and thank you for joining me. My name is Lynn Schaefer-Alphonse, and I'm a nurse practitioner with Seattle Rheumatology Associates. My presentation today is titled Forms and Blood Tests. What do these mean, and how can they help me track and manage my RA? Do you sometimes feel when you arrive at your rheumatology office that you're inundated with questionnaires and you wonder, why do I have to do all of these blood tests? Why are they important, and what do they tell us? Well, I have to say that oftentimes patients come to my clinic and say, oh, Lynn, I'm fine, I'm good, I'm stable, I'm so-so, things are okay. But you know, their joints and their behavior show otherwise. I'll see patients struggle to get onto the exam table. I'll see them limping down the hall or having difficulties bending over to take off their shoes. Forms, blood tests, and patient evaluations give us a better picture of control, and then steps can be taken to better manage the disease. Why are measures important? Well, if you can't measure something, you can't improve upon it. The goal for everyone should be to be as functional and comfortable as possible. So frequent clinical visits for evaluation and measurements that help us know how you are doing will allow for changing and tweaking of therapy in order to achieve that goal. There are a variety of measurement tools used in order to gauge disease activity. Unfortunately, there is no one perfect test that can give an accurate picture of current disease activity. Pain can come from other sources, or there may be joint damage and disability from the years when the disease was active, and that can skew the results. Thus, we often rely on a combination of modalities to help us. So what are these different modalities? Well, methods range from blood tests, such as the Vectra DA test, to the inflammation marker tests or acute phase reactants, commonly known as ESR or CRP. There is imaging, such as X-rays, MRI, and more commonly in a lot of rheumatology clinics these days is the use of ultrasound. Patient assessments, such as the Health Assessment Questionnaire, and healthcare professional assessments, such as the Tender Swollen Joint Count. There are composite measures, such as the DAS-28, or the CDI, which is the Clinical Disease Activity Index, or the SDI, which is the Simplified Disease Activity Index, and these use a combination of modalities to give an actual score that can be tracked from visit to visit. Let's start with laboratory tests. I know I always get a lot of questions about laboratory tests and why are certain blood tests drawn at only one visit and perhaps never drawn again, and why are other blood tests checked frequently, almost every time I come into the office? Well, the upside of blood tests is that they are objective, meaning they're not influenced by personal feelings or opinions. The downside is that they have to be done a couple of days before coming into the office so that they can be used as scoring part of your disease activity, and sometimes that can be a hardship. That said, there are certain labs that are drawn to assist with diagnosis. So those are usually just one-time tests, and we'll go over some of those. Others are drawn frequently as they help calculate disease activity. So let's talk about tests that would be used for an initial diagnosis. These are not markers of disease activity, and that's why they're not typically rechecked on a regular basis, though a high rheumatoid factor and CCP do often indicate more severe or more aggressive disease. So let's start with the rheumatoid factor. This is an autoantibody that's found in about 80% of patients with rheumatoid arthritis. That said, 20% of patients will not have a positive rheumatoid factor. It doesn't mean that they don't have rheumatoid arthritis. It simply means that they don't have a positive rheumatoid factor. Also, keep in mind that some people can have a rheumatoid factor that's positive, but not have the disease. Sometimes we see an elevated rheumatoid factor in patients who have infection or may have cancer. The CCP, or the anticyclic citrullonated peptide, is more specific for rheumatoid arthritis than the rheumatoid factor, and higher levels do indicate more aggressive disease. Sometimes I'll check an ANA. This is often elevated in patients who have autoimmune disorders like lupus, although it can be elevated in patients with rheumatoid arthritis. And finally, another blood test that we will draw to get an idea of potential diagnosis is an HLA-B27. This is a genetic marker. It's seen more frequently in patients who have a spondyloarthritis. A spondyloarthritis, for some of those of you who aren't familiar with this, would be a disease such as ankylosing spondylitis or psoriatic arthritis. So it's similar to rheumatoid arthritis. However, there will also usually be some inflammatory back pain. There may be inflammatory eye disease such as iritis or uveitis. And there also may be enthesitis, which is areas where tendon and ligaments insert into bone that are inflamed. So this is found in about 8% of the general population, but of course it doesn't mean that automatically if you have a positive HLA-B27 that you have a spondyloarthritis. So again, these are 4 tests that are usually one-time tests that help us get an idea of what the diagnosis is. Is it rheumatoid arthritis? Could it be psoriatic arthritis? Could it be an autoimmune disorder such as lupus? Lab tests often checked as a gauge of ongoing disease activity include acute phase reactants, and these are tests such as the erythrocyte sedimentation rate or the CRP, C-reactive protein. And elevated scores may indicate active inflammation. However, these tests are not specific to joint inflammation, and they can be impacted by other factors such as infection or congestive heart failure. Some patients tend to have normal inflammatory markers despite obvious evidence of swollen joints. In those cases, the inflammation markers aren't terribly helpful, and you may find that your provider stops checking these on a regular basis. The CRP is more specific. It changes more rapidly than the ESR, so you may find that your provider only wants to check one of these tests, perhaps the C-reactive protein. Lab values do vary from lab to lab and vary between men and women. What about the vector DA, or the vector disease activity test? I'm sure some of you have already had this lab test drawn. It's an interesting test. It measures 12 proteins that are often elevated in patients with active rheumatoid arthritis. All of these proteins carry different weights when computing the score. So an algorithm is used to compute that score. One will get an actual number or score that will show low, moderate, or high disease activity. Those with a high vector disease score are at the greatest risk for future damage. One other useful thing about the vector DA is that it's not impacted by other conditions. So for example, if I have a patient who has rheumatoid arthritis and they also have osteoarthritis, and I'm not quite sure the source of their pain, I may do a vector disease activity test. And if it comes back as low disease activity, that gives me better guidance in terms of how to treat. I may not change their treatment for rheumatoid arthritis, but I may be more aggressive in treating their osteoarthritis or their other pain source. How often this blood test is checked is really up to you and your provider. I tend to check it when I feel a patient's not doing very well, and certainly if they have a moderate or high disease activity score, I would be thinking about changing treatment. If I change treatment, I may recheck it in 2 to 3 months just to see how they're responding to treatment. What about imaging? So we talked about lab tests, but how helpful is imaging when it comes to tracking your rheumatoid arthritis? Well, it can be helpful in assessing joint damage as well as joint inflammation. X-rays don't give an indication about current disease activity, only past damage. I like to get baseline X-rays when a patient first establishes, but I would only get X-rays periodically after that, perhaps every couple of years. But I would rely on other measurement tools to assess current disease activity and change treatment if necessary to slow or halt joint erosion. I don't want to see joint erosions. If we start to see joint erosions, it means that we're not catching the signs that the disease is active today. Ultrasound, as I stated before, is being used quite often in rheumatology clinics now. It can show evidence of current inflammation. If a provider palpates a joint and is unsure if it's synovitis or swelling, or perhaps only past damage with no evidence of current disease activity or synovitis, or maybe it's something else altogether, such as a cyst, ultrasound can usually enlighten the clinician. MRI, it's useful, but it's expensive, and so not usually recommended or commonly used for routine monitoring. It can pick up bone swelling or bone edema, and this is quite predictive of future erosion. So we've talked about measuring disease with blood tests as well as imaging. And now we get to the forms and patient measures, the things that you have to fill out when you come into your rheumatology office and you wonder if we even look at it or even read it or even record it. Well, one thing we might ask patients to do, which is very simple, is simply to rate their pain or rate their level of fatigue or rate how they're doing globally. And that might simply be a question such as, rate your pain for me. 0 is no pain. 10 is terrible pain, the most pain you've ever experienced. And you may give me a number such as 5 or 4 or 8, and that's recorded. And why is that helpful? Because I can ask you the same question in 3 months when you return for follow-up and get another number. And if I do that every time you come in, we can kind of track how you're feeling in terms of your pain, how your disease is doing globally, or even how your level of fatigue is. Sometimes we give you a little form, this little skeletal creature with large hands. It's called a homunculus. It has circles on the joints where you can pencil in your answer. So we're basically asking you to pencil in which joints of yours are tender and which joints are swollen. You may be asked simple questions such as, do you have morning stiffness and how bad is it and how long does it last? Answers, however, I find are quite subjective and they can be influenced by other factors. Of course, your fatigue is going to be quite bad if you have a newborn baby and you're not getting a lot of sleep, or if you're really stressed at work. Your pain may be greater if you also have a comorbidity of fibromyalgia or osteoarthritis or just injured your ankle. A more complete picture of how a patient is doing from a functional standpoint may be by administering the PAC, or the Health Assessment Questionnaire. And this measures 8 categories of daily living activities. Responses are added up, divided by 10. A score of 3 is the highest, and it signifies the inability to do these activities of daily living at all. And so these questions may be, are you able to tie your shoes and dress yourself? And if you're not able to do that at all, you would get a score of 3. If you were able to do that without any difficulty, you would get a score of 0. What's really useful about this is that there's an actual number, and if we administered this every time you came in, we would get a good idea of how you're doing from a functional standpoint. What about healthcare professional measures? So in terms of clinician measurements, often the healthcare provider administers a joint count during a clinic visit, and this is usually a 28 joint count. Which joints does it measure? It measures the shoulders, the elbows, the wrists. In terms of the hands, we're measuring these joints, this knuckle group, these are the MCPs, as well as these knuckle groups, these are the PIPs, and the knees. When I palpate, I'm asking a patient to let me know if the joint feels tender. So it's more than just a pressure sensation. And I'm using the same amount of pressure on every joint, which is the pressure to blanch my fingernail. As I'm going along, asking the patient to let me know if the joint is tender, I'm also feeling for kind of a boggy, soft feeling of the joint to let me know if there could be swelling. So based on the joint count and the information that you share with me in terms of your level of pain or your level of fatigue or the amount of morning stiffness you have, I may come up with a global assessment looking at all these factors, and that may again be on a VAS score, a visual analog score of 1 to 10 or 1 to 100. Composite RA disease activity measures are probably the best because they use a combination of lab tests, joint counts, and patient and healthcare provider input. And that gives us a better idea of current disease activity. What's beneficial about these tools is that they give an actual score, and that can be tracked from visit to visit. If scores start to rise, it can signify that the disease is more active or no longer responding as well to current treatment, and then action can be taken. Key takeaways. As you can see, whether we use blood tests or imaging, questionnaires, or joint counts, there's no one perfect test. Using more than one measure can give a more accurate picture of your RA activity level. Why is this all important? Remember again, if you can't measure it, you can't improve it. Here's a framework for setting a goal, and it's called SMART. It looks at specific, measurable, attainable, relevant, and time-bound goals. Let me give you an example. An example of goal with SMART is to put my rheumatoid arthritis in low disease activity as demonstrated by a vector DA score of 29 or less and a patient global of 2 or less so that I can plant a spring garden in 6 months. So be specific. How are you going to measure it? I want to obtain low disease activity. And so that would mean a score of 29 or less on a vector DA, or looking at my globally, how I'm doing with a score of 2 or less. So we're very specific, and these are ways that we can truly measure your disease activity. It has to be attainable. If you need to achieve low disease activity and you're currently in moderate or high disease activity, obviously steps need to be taken to change your therapy. And we all know that it can take a while for therapy to start. So 6 months is a reasonable time frame to determine if a drug is working. Is it relevant? A goal should be something that you really want to be able to do. In this case, the patient wanted to do some gardening. It was an activity she couldn't currently do or couldn't do well. And then if it's time bound, it puts the pressure to get the disease under control now. There are many tools that can help you track your disease activity. There are phone apps such as MyRA or Point of Care Rheumatoid Arthritis Patient Companion. There's WebMD Pain Coach, as well as Track and React through the Arthritis Foundation. Simply having a written diary can help people track their disease, and practice websites in different clinics are usually very helpful. So in summary, hopefully now you see the need for questionnaires and lab tests, imaging and joint counts. These tools give us a more complete picture of current disease activity so that therapies can be tweaked or changed, particularly when goals are not being achieved. SMART can help you set timely and achievable goals, and there are numerous resources that can help you track your progress. That is the end of the discussion. Thank you so much for joining me today.